Welcome to this special joint plenary session that we're going to have this morning to kick off the kind of pre-Congress activities. My name's Dr. Ursula King. I'm your MC for the 3 days, and I'll also be the facilitator for this particular panel event. We've got a bit of a treat for you this morning. For those of you who've had the chance to be here for the 25th World Congress of the Federation of Hospital Engineers, we're actually putting those people together with the World Hospital Congress leaders in the health field. So what we're actually going to have is a combined experience between the people who actually develop the structural aspects, logistical structural aspects, design, so forth, of the physical realities of our health world, and those who actually occupy the spaces. The people who actually the ones who actually do the work inside those spaces. And the metaphor that we're using today is actually in relation to our ability to be prepared. The context of this conversation is actually disaster response and preparedness. And we're privileged to actually have 3 speakers with us this morning who are going to give us a brief presentation each. Then we're going to move into a facilitated conversation. So joining us this morning, we've actually got Bronte Martin, who is the Nursing Director of the Trauma and Disaster Critical Response Centre in Australia. She'll be our first speaker. Following her will be Glenn Keys, who's the co-founder and co-executive director of Aspen Medical in Australia. And the third speaker we have is Berna Marcelino, who's actually the Provincial Director of Standardization for the British Columbia Clinical and Support Services. Each of our speakers will give you their take on where we are in relation to disaster preparedness at this particular point in time, some of the key issues we need to consider in terms of the stuff as well as the people that occupy those complex spaces, and then we will proceed into a discussion to try and nut out some of the nuances of that. So can I please ask you to join me this morning in welcoming our first speaker, Bronte Martin.
Good morning. Thank you very much. It's a pleasure to be here, and hopefully, first cab off the rank, you're all fully caffeinated and can keep up with me as we progress. So my job is a very privileged position that I have, which is one that has me going to very far-flung places around the world, but pleasingly representing Australia in doing that, in leading that space. Glenn also works very actively in that space, and together, along with Berna, I think we're going to give you a very interesting session this morning, so hopefully you enjoy. So my story really starts with Haiti in 2010. So for the world, really, in terms of humanitarian aid and disaster response, it drastically changed. This was a watershed moment for us globally in how we choose to respond, and it was a significant crisis that generated a hallmark in transformational agenda of reform for the United Nations and many other global partners around the world. We saw over 450 medical teams responding in a very uncoordinated, chaotic way, where there was unquestionably overwhelming humanitarian and healthcare need. But what we very disappointingly saw was a whole bunch of folks that really weren't qualified to do what they were doing all kinds of really very appalling and heartbreaking things like you see there on the screen. So we had some teams reporting in peer-reviewed journals, actually, amputation rates of up to 64%. You don't need to be an orthopaedic surgeon or a rehabilitation specialist to look at that X-ray and think that something is wrong. The long-term lifetime outcome and impact for those individuals that are left with a stump like that in terms of meaningfully returning to society is significant, and the health burden that comes with that on a system that was already struggling pre-disaster is really unfathomable. So what happened? Well, the world got together, and the UN General Assembly in 2015, they transitioned to their transformative agenda and listed 17 Sustainable Development Goals, affectionately referred to as SDGs, and you'll notice that health is number 3. But I would argue that all of these have direct relevance when we specifically think about disaster risk, disaster resilience, preparedness and response. And that means that we're a cross-cutting theme, and we have to work with all parts of the sector and really take a holistic approach to how we manage and integrate in times of disaster, but really, like most things in healthcare, the front end and the preparedness part can go a long way to making our response part much easier. We also had, as a result of that, the Sendai Framework, which came in 2015, which is a 15-year plan, much like the 2030 SDGs. And it is very specifically related at disaster risk and reduction, and it builds on the previous work of the Hyogo framework. And again, very broad and big picture. But what does that mean for us? Well, if we look at the 7 targets, they seem pretty simple. But if you have a think at a national level and then a local level, how you go about implementing that and how you network those together, it becomes a bit of an unimaginable task. And so there are many different programs that work to map these together. If you look at the 4 priorities, I think we would all agree globally these are very important. Understanding disaster risk, which is very specific to your region and also your country and your national agenda, but also your climate, your population and your socio-economic determinants. Investing in disaster risk reduction for resilience. Let's be really honest, it's not the sexy part of disaster response, it's not the CNN factor, but again, if you put significant investment in that front end, you can make a big difference in the outcome. Strengthening disaster risk governance is one that we need to work very closely with local governments and those that are in charge, and enhancing to disaster preparedness to build back better. So that's really the resilience part, and that's having the capacity and the resilience in our health system specifically to be able to deal with surge events. So we then moved forward from that, and we had Ban Ki-moon make a very powerful statement at the World Humanitarian Summit in 2016. And the slide you see on the left there is the World Health Organization's prediction of if we just invested in our health systems, we could reduce 97 million premature deaths in the next 15 years. Just pause a moment and think about that. That's quite a mammoth impact and a sizable dent in outcomes for people around the world. But what we need to do is understand that it's not necessarily coming in on the cavalry ride and those of us internationally going and helping our neighbours if they need it. That's great. But actually, if they are able to do it themselves, then we should support that and do that. And so the transformative agenda of being as local as possible but as international as necessary was born. We also, very specifically talking about healthcare, we looked at emergency medical teams, and we had a good understanding, essentially, post-Haiti, that good intentions are no longer enough, that principles, standards and quality do count when you're talking about delivering care in any context, including disaster response. And that in doing that, particularly in disaster events, healthcare is very complex and it has quite a significant operational and logistical burden that goes along with that, and we need to understand that, and that's just as important as the clinicians. National leadership is of course key, and coordination, and we really need to govern that globally. So the Emt Initiative was born, and that is a group that is led by the World Health Organization and has 5 main themes, which again, I won't go in detail, but you can see linked back through to both the Sendai Framework and the global SDGs. They published the Blue Book, which is the picture I showed you before, which is really the Bible for emergency medical teams, and it lists very clearly the standards and what that actually means in practice. The guiding principles and the core standards are applicable to all those that choose to do them, and you'll notice there that really specifically means being safe, timely, effective, efficient, equitable and patient-centred in your care. Seems like common sense, right? It's kind of crazy that we would have to tell people that that's what they need to do. The core standards really relate to how you interact with each other and host governments, and the technical standards very specifically relate to what type of EMT you would choose to be. Which brings me to my next point. So what the global standards do alongside of host systems is map. If I'm an international team coming, what is my capability and where does that fit in a host system? Because we're visitors in a system when we come to provide assistance. We shouldn't presume to take over or do something in isolation, and it should be in accordance with the host government. We have to have a quality assurance program to go with that, and we have very successfully, I'm pleased to report, 21 teams who are now globally verified, and I'm quite sure Glenn will probably tell you that Aspen were one of the most recent and certainly the last Australian team to be classified, and the Australian government team was classified in 2016 as the 4th country in the world to do so. We know that health systems have very specific needs in times of response, and we know that the front end of the system and the national system is paramount in saving lives. We also know that it's very predictable what's going to happen to your system. We know that immediately after an event, you're going to have that big spike that you see there, which is this one just here, and particularly for sudden onset disaster. And we know that if you don't do anything about that, you're going to lose lives, but we also know that the destruction that comes with the system then leaves you with further issues that will then cause public health disease, for example, and other system issues that I suspect Berna may talk to you about. We also know that if you ignore core business for long enough, it becomes a disaster of its own right, and that the system won't be able to cope unless you choose to do something about that. And we know that they very closely map to roughly 14-day blocks. We've looked at the last recent events. We can also predict, for example, the number of injured versus the number of dead very early on to have an understanding of what the healthcare need and burden might be. And most recently, if you see on the right-hand side there, that looks at tsunamis, and if we reflect on the Sulawesi earthquake, you will see that those numbers are quite clearly being reflected, that the number of dead, unfortunately, is very high compared with the number of survivors. In terms of predicting your acute care surge capacity at a grassroots hospital or clinic level, we like to use the 7S approach. So that's staff. You need to have the personnel who are equipped to do that and support that surge. The stuff, which is all the clinical consumables and things that go ping, and the logistical support that you need to do to deliver your healthcare safely and effectively. You need space. You need somewhere to put your patients when there's an overwhelming number, and you need a system and a way to deal with that. The safety and security really relates to both your staff, your patients, and your work environment, and that explicitly includes things like infection prevention and control. And then the ability to support the surge is an understanding of what previous events you might have had and what are the known stresses on your system, so that you can very easily predict what your needs might be ahead of time. So in closing, what really are the core principles of an effective response? Well, you need to be effective and appropriate. That means that surgical field hospitals should not be turning up on day 30 post-event. They need to be timely. And they need to be fit for purpose. They need to be credentialed. So if you want to do surgical procedures, you need to have trained surgeons who are credentialed and do that job in their daily practice in their home location. They need to have an understanding of translating that clinical practice into context and understanding what it's like in a resource poor or resource low setting with those other challenges. They need to be self-sustainable and not a burden on the host country they're going to assist. Nobody wants to create more disasters other than what's already occurred. And lastly, quality care and standards do matter. It doesn't matter where you are and what you're doing. The patient comes first, and the patient needs them utmost. So in closing, I'd like to say thank you very much. That's a very, very fast whip through what disaster preparedness and resilience is looking like leading into response, which I'll hand over to Glenn. This is the Australian Field Hospital in Tacloban and post-Typhoon Haiyan, and that gives you an idea of what an austere field hospital might do with 60 beds and 2 operating theatres. And we saw 3,000 patients in 21 days with 500 inpatient stays, and we did 300 surgical cases in our operating theatre. Thank you very much.
Thank you, Bronte, for kicking us off. So now we have Glenn, who's actually going to follow on and talk a little bit more about the people side of this equation. Glenn?
Good morning all, and it's a real pleasure to be here, and it's a fantastic segue from the structure, the Blue Book and the logistics to then move into some delivery. So what I'd like to do is, I'd like to move the slides on. There we go. A little bit just who, if you haven't heard of us, we are a commercial entity. We were founded in 2003. We're Australian owned and headquartered, but we're operating in 16 countries around the world with about 2,500 staff now, most recently deployed on major projects or on disaster areas. So what do we do? Well, people say, are you project management in healthcare? We're actually healthcare project management. We provide the people, the clinics, the hospitals, mobile facilities particularly, as well as training and support of staff. So we do work for two key areas. Obviously, government areas. We've done work for USAID, DFID, the World Health Organization, as well as corporate entities. And there's a lot we learn from the corporate side that can be brought to the disaster management and the response side. And what I'd like to do is focus on a couple of the key projects that we've done for WHO and for international aid agencies. Our model incorporates a rapid response, fantastic people. We all know that hospitals are just buildings without the quality of staff that we have, but we also overlay that with an incredibly strong project management approach, no matter where we're operating. So I'll talk a little bit about the Ebola outbreak first in Sierra Leone. This was our timeline for our Australian project. You might remember in November, Prime Minister Abbott at that time announced that Australia would be sending a response and it would be us. We were prepped for people to ring in and contact us through Facebook and LinkedIn. We had over 2,000 people ring in the first 48 hours wanting to deploy. It was an incredible response, I think, on behalf of the Australian healthcare community. We had a project office that day. We had people on the ground within 36 hours. We stood up our facility within 4 weeks from scratch. You must remember the Australian government had no in-country consulate support, so we were working from UK guidance, and we were operational before the end of Christmas. And our very first Ebola survivor came out on the 30th of December that year. You can see 3 areas there. Hastings was where the Australian government site was, but we ended up taking over 2 extant clinics in 2015 off the British government, and they were down at Kerrytown and Godrich. So Dr. John Gerard, Director of Infectious Diseases and Immunology, is actually a quietly spoken man, difficult to get to speak voluminously, but for him, he described this as the worst affected city in the worst affected country and the worst ever epidemic of the most lethal communicable disease known. It was hard to make it worse than that. For those who are not familiar with what an Ebola treatment centre looks like, this is the layout. This is actually the facility that we built for the Australian government at Hastings. And we were responsible for all aspects here, not just all the clinical service delivery, but all the catering, the accommodation, cold chain logistics, really critical aspects, sewage particularly, considering the transmissibility of diseases. So you can see it's an incredibly large, complex facility in a really remote and challenging operational environment. Some of the challenges we had: situational awareness, training, having to train our staff before they left Australia, but training over there as well. Across all of our sites, we had about 200 expats, 800 Africans that we had to train. We had to construct things, logistics, even things as basic as gravel for drainage areas was not available. Recruiting, retention of staff, and then our safety and security of all of our staff. So we went in there on behalf of the Australian government. New Zealand government, you may not know, but they were providing clinicians to us as well. It was a 100-bed Ebola treatment centre at Hastings. We had, one thing I'm very proud of is we had 0 team infections, either in expats or Africans. It was an incredible outcome, but a really strong component was due to that operational project management and the training piece. And then, as I mentioned, we took over the Kerrytown facilities on behalf of the UK government. Most recently, we've been in Mosul. I will actually just skip past this video in the sake of time, but I have provided the material to the organisers, so this will be up on the website and you can watch that video. The operational timeline, back in November 16, the WHO built 2 trauma hospitals and 2 maternity hospitals. They went out to all the member nations of the EU and the UN, and they didn't get a single response. They then requested a capability statement from us in February of last year. We had a team on the ground within about 48 hours doing a site survey. 2 weeks later, we signed a contract with the WHO, and 2.5 weeks later, we opened the first trauma and maternity hospital at ABTHA. As you can see, the range of activities, we ended up opening 2 trauma, 2 maternity hospitals. We opened another trauma hospital at Haman al-Alil. When there was the Iran-Iraq earthquake, we deployed teams to support the response. We had teams on the ground within 13 hours of the earthquake. And you may not be aware there was a bird flu outbreak as well. We did all of the protocol, procedure, development, response. The thing we're very proud of is we didn't just run these and deliver care for the escaping civilians. We actually then trained, worked with the Iraqi clinicians whose clinical standards were outstanding, developed with them, co-designed, developed their procedures, and handed those facilities over to the Iraqi Ministry of Health. The environment, this was actually a photo taken when I drove through Mosul. Our headquarters was in Erbil, which is the capital of Kurdistan in Iraq. It's beautiful. It's like a little mini Dubai. 23-storey hotel, cafes. An hour and a half to the west is Mosul. Incredibly challenging environment. Our locations, you could see Mosul, Erbil there. These are right up in the north of Iraq. And you can see where we were there in ABTHA and in Hajj Ali and in Aman al-Alil. So really, really quite remote locations. In Al Sulayman, over on the right there, you can see where the earthquake response was. And then later we responded down in Al Qaim, which was where they pushed IS out into Syria. So this was really non-linear project management. You don't get to do one thing and then build to the next and build to the next. We were researching, planning, reconning, all at the same time. You couldn't wait on singular approvals. You had to delay, get out straight away. You couldn't wait. An enormous amount of concurrent activity and speed, but with really, really strong risk management and risk assessment was really the key. Security was absolutely critical. We were very, very close to Mosul. We could actually see where the mortars were landing. And so for us, having security for our staff and an experienced team was really critical. We did have T-walls around the hospital for protection of our staff, but we tried to make it as subtle as we could due to the fact of being the hospital. Logistics, we had to do everything except build the facility. So we were required catering, accommodation. The maternity facility obviously had to meet all the cultural expectations. It was 100% female staff, so we had to have managed accommodation, cleaning, etc. There were no mains power or water. There was no septic, and all our own catering. Human resources, people will make or break your deployment, and I think having that trusted core of non-clinical professionals for the ops, logistics, security, finance, and HR and admin is really, really critical. It wasn't a mistake that a lot of our staff were ex-military. They deployed into these environments and they understood how to do it. Our HR processes to source people were really critical. We had a very comprehensive credentialing, and when you're trying to do credentialing across 25 different countries for deployment, including countries like Iraq, where there isn't a lot of data to draw on, is really quite challenging. But the quality of staff, clinical staff, is really, really, really critical. So in summary, what did we do there? Well, we had 3 trauma field hospitals, 144 beds, 6 operating theatres, 3 ERs. We had 2 maternity hospitals, total of 40 beds, very rapid response, international team, 25 countries. We treated almost 48,000 civilian casualties surgically. We delivered almost 3,000 babies, very low mortality rate of 0.4%. Just to create a section of the humanity, this photo is very powerful. I actually held this young baby in my arms. This baby, we didn't know who he was. He'd been left in a street as bait for people by IS. He was crying when adults would come out to rescue him. IS snipers would shoot the adults. By the time he was finally rescued, his arm had been chewed off by a dog, and we had to operate on him, saved his life. You would never know looking at him. Our paediatrician said she's dealt with thousands and thousands of babies, but he's the one she wanted to take home. Very quickly then, in minimising the impact for staff, it's critical that we care for our team, very strong induction model. We had full-time psychs with all of our staff and a long-tail employee assistance program supporting family members as well. Thank you very, very much, and I look forward to chatting later.
Thanks, Glenn. As you can see, there's an enormous amount in these. I just want to get this a taster, and then we can actually explore these questions in more detail. Now, moving to our third speaker is Berna. Berna's actually going to talk to us about something that doesn't come up as much overtly, but perhaps underpins a lot of what we do in this space, which are issues of ethics. Berna.
Thank you. I wanted to thank everybody for the invite. It's quite the honor to join the panel today. At the end of my presentation, I hope that your takeaway is that an ethical allocation framework is quite essential to ensure that there'll be less people like me in the healthcare system, and I'll say more about that later. This is not British Columbia, but it could have been. This summer, we had at some point 1,500 fires burning throughout the province. And speaking of our province, I come from beautiful British Columbia. We're really waiting for the big one. It's not if, it's when a major earthquake is going to happen. In fact, we're so sure that it's going to happen eventually that the government has an immediate response plan. And in this response plan, the scenario is that a major earthquake happens. It's a shallow one. And that it actually affects two of our most urban, large population density areas. And they estimate actually that if this happens, there'll be a lot more people injured, and it will far outweigh the fatalities, the number of fatalities. And the estimation is that there'll be about 52 people injured per 1,000. And so if we actually do translate that in our population of today, it means 155,000 injuries in that single incident. I think Bronte talked about this a lot. You know, in a time of disaster, there'll be a lot of challenges. Multiple systems and aspects of daily life will be affected. You know, the transport routes will likely be impassable. We'll have some system issues with communication. There'll probably be some network overload, irrespective of the technology that we use. So nevertheless, really the distribution network will be disrupted at a time like this. So there may be some neighboring countries, neighboring provinces who have supplies would want to help and provide some relief to British Columbia, but at the end of the day, there will be challenges in getting those supplies. So for those reasons, we do expect that demand for medical supplies will far outweigh the available supplies that we'll have. So the hospitals will already be caring for the people before disaster, and then they'll experience this huge surge of injuries, people coming in during this disaster. The clinical and operational folks at those acute sites or maybe makeshift care locations at that point, they'll be dealing with many disaster situation factors, and they'll make life-changing decisions rapidly, really fast. All the while, there'll be lots of unpredictability, lots of uncertainty, lots of unfamiliarity in very vulnerable system. It's really for this very reason that we need an ethical decision-making framework for allocation to support the healthcare workers in their decision-making, to prepare them so that they're not flying blind, and then eventually left to pick up the pieces because of their decisions in the aftermath of it all. I've got a clinical background. I'm actually an OR nurse by trade, but I've been working in supply chain for a while now. And you're probably thinking, what's a person like me doing with a project like this? So I want to tell you my personal story that kind of led me to this path. I mentioned to you earlier that it's essential that we have something like this, so there'll be less people like me in the healthcare system. In the early days of my taking this position, we were hit quite hard in the province with a product shortage. And because I have the clinical background in supply chain and my team have the clinical expertise, supply chain really looked to me to make the decisions on how to allocate the little product we have left at that point. Without guidance on how to allocate, the decisions really weighed on me. I wasn't sleeping very well, kept me awake at night. I wondered many times if I was making the right decisions. I wondered how my decisions actually affected people's lives. So it was after the fact when I was able to actually reflect that I realized that I was experiencing moral distress. In a disaster situation, like this gentleman here, the healthcare worker, the administrators, they'll be constantly prioritizing, they'll be constantly triaging, while all the while they will be dealing with their own loss, probably dealing with their own trauma, very heightened emotions. So that time is not the time to be reflecting on their values and the values of the population that they care for. It's really not fair that they're subjected to those ethical dilemmas without adequately preparing them for it. And because ethical allocation is not rocket science, it's not black or white, there's lots of grayness in between. Sometimes there's not really one right answer. It's really the reason why we have to have an ethical allocation framework is to provide guidance and pathways to enable alignment of those decisions. And in a disaster, ethical challenges will be quite different than your usual medical ethics, what you usually see in your everyday life. The situation will be quite related to population health more than individual health. When you have to prioritize and triage during a disaster, your aim is to maximize the benefit to the society as a whole. And unfortunately, that may be at the expense of some individuals. So while our usual loyalty is to our individual patient during the devastation, the resource allocation decisions will be based on collective rights. And so I told you earlier I was having that moral dilemma, so I talked to my VP and I said, I think we really need something. I didn't know what it was going to be, but we set out anyway and got a committee, a bunch of committee members, and it consisted of interdisciplinary and cross-provincial group. And so this is just sort of a summary of what we come up with, little part of a many-page document. The prioritization criteria that you see on the screen is used when assessing need and allocating products across different sites and health authorities for British Columbia, when you're looking at conservation strategies at a site or a unit level as well. The criteria is really meant to be used by decision makers during a shortage, and those decision makers should have the background in the affected clinical area so that they can actually go and apply the criteria and make those quick decisions. It's important to note that the values we settled on considered the values that are quite important to our society and to our population. It's within our context. So while many may not agree with our framework, this is what we hold true as people. The process that we went through allowed for that open and transparent discussion by professionals and patient representatives, and afterwards we did send it out for a large-scale consultation before we finalized the criteria. The decision makers who will use this criteria should have the best information that they could possibly have. So for example, who will actually require the product in a life or limb-saving capacity? How will the shortage affect the healthcare providers and the public? And if the shortage will result in severe physical pain and suffering. Our ethical priorities are unprejudiced of ideological variables. So we're not considering race, we're not considering religion, we're not considering socioeconomic status, we're not even considering behavioral concerns or past history of the patient that may have exacerbated the patient's condition. Our approach is based on understanding that every life is equally worth saving. It recognizes that life itself, freedom from pain, and suffering are essential elements of quality of life. The value that should determine who will receive scarce resources is really based on equity. We're distributing based on medical need with a view to preserving life before seeking to improve the duration or quality of life. And before we could actually go and implement this in the whole province, we've had to implement it impromptu. We've had a shortage of IV diluents, and for those who know what that is, you know it's used everywhere. And at some point, we actually thought that we were going to run out. So we had to go and implement the ethical allocation framework that we had. I thought it was actually good. You know, it was a good test drive for the framework. It would allow us to actually learn and continuously improve our process. Will give us time to pause and reflect. And there were so many learnings from that sudden implementation. And I'll just give you some of them. Probably the most important for me is the importance of helping people through that dual loyalty dilemma. They really need to understand that the benefit to the larger population outweighs the benefit to the individual patient at that point, and that our moral obligation is to act on behalf of all the affected people. Another learning is that context is quite crucial, so the decision makers must understand the impact of their decisions and who those impacted will be. And usually the situation was quite different from one area to another. Communicate as early as possible and as often as possible. We needed to deliver appropriate and updated information regularly to our healthcare workers. We just did not want any misinformation out there because misinformation leads to mistrust. We also worked closely with our ministry because we needed to inform the public on how we're actually handling the situations and the justification of why, who, and who we're giving it to. They needed to know that everything is being done to provide quality of care during the time of restriction. And it's through that transparent process that we built trust. I have 0 minutes, so I think what I will do now is to just close it off with a quote from Martin Buxton. And he says it in the context of technology assessment, but I think it's quite relevant for disaster planning. And he says, it is often too early until it's too late. So I think it's quite important that we keep that in mind so that, in times of disasters, the resources that we have, we can actually have a systematic way to maximize the overall good with whatever we have left. Thank you.
Thank you, Berna. So let's maybe start at the macro level. Bronte, something you mentioned was that one of your targets was to increase international cooperation by 2030. That's not long for such a important focus. How are you proposing that we go about doing that?
Good question. So I guess the first statement is there has been rapid, significant transformational change across all global partners and agencies. So that's from UN right down to national level and jurisdictional levels. And so how you apply all of those targets changes at each of those levels, but they should link together. So the Office for the Coordination of Humanitarian Affairs, so OCHA, has a strong lead in coordinating international partners. But what we're seeing globally, and particularly very strongly in our region here, close to home to Australia in Asia Pacific, is that there are regional structures that are being in place to better coordinate regional or national needs on behalf of the host government. So, as I mentioned, who are we to presume to know what the needs of another country are? They should be enabled and empowered and supported to coordinate and do that themselves where possible. But there are some situations where the need is clearly overwhelming and they need additional assistance, and we need to be respectful in how we go about that.
So how are you respectful in
how
going
we're
about
respectful?
that?
Yeah. So for us, and I'm going to focus very clearly on the acute care health sector, which is my main area of expertise, and that's the Emt Initiative. And you saw those 5 themes that we put up. And the bulk of the work that we do, aside from the quality assuring of teams who are going to offer assistance, so countries know they're accepting, if they wish to accept, qualified teams, and they know the service delivery health effects they're going to do, is national capacity building. So that's working on a daily basis throughout our region. For me, as the current chair for Asia Pacific for emergency medical teams, is going and working with all the different countries in our region and listening to them and understanding what their needs are and where they would like support, and then understanding in reverse what we know international teams arriving will put stress on a system. So, for example, I went and worked with the government of Vanuatu in the Cyclone Pam response, directly within the Ministry of Health, to assist them to manage the incoming teams and understand where their needs were best used, and where required, politely decline, because that's not required. Thank you very much for your thoughts and prayers, but we don't need you at this time. And that's a strong message we're seeing globally. So we see that also coming from the Latin America's region, very, very clearly. And we've seen it very clearly from Asia, most recently with the Lombok and the Sulawesi earthquake response, where they've specifically not requested international assistance and declined. So the era of teams just arriving and people coming because they believe there is a need rather than being invited is upon us, and rightly so.
I like that phrase, the era of teams is just arriving. Glenn, that's an interesting point, because you're playing in these international complex spaces where I can imagine the concept of assertive politeness could be quite challenging when there's an immediate and complex need in front of you. How, in your experiences, have you been navigating this kind of need for respectful but assertive international collaboration?
I think it's much easier for us because we only ever go in when we are asked.
Yes.
So whether it's a donor nation or an international NGO like the WHO, ask us, that's when we go. So they've already been through that process of working out who should be in. I think what we're also starting to see though is there's been a lot of immediate response, go in 6, 8 week, maybe up to 3 months, but challenging for a lot of responders to stay past that. That's something that people are now identifying is, to use the analogy, it's okay to run in and put out the fire and walk out for the hero shot, but someone still needs to go back and rebuild the house and put in smoke detectors and proper wiring. A lot of that has not happened in the past. And so that's where people like ourselves are now doing a much more sustainment role. And a handover role. You talk to some donor nations who say, we come in to help, and then we say, okay, how do we now hand back to you? And then we're just stuck. And we feel like we either have to walk away and drop a capability or be there forever, and then you're not actually growing a capability in country. So where we're starting to see our engagement is in a couple of key areas. One is that sustainment piece,
Yep.
But the other is around, in the same way that nations are picking who they need and where they need them. Donor nations and agencies are also deciding where they want to go as well. And so some key areas, pandemics is one, and trauma surgery and man-made disasters, read war zones, is another, are difficult to find people to go in to do that work. So those are sort of two key areas, but for us it's very easy. We're never anywhere where we're not asked to be.
So, extending that into this people side of this equation, how do you find the people that you need to be able to occupy what sounds like an expanding space? So not just, as you said, the hero shot, come in, put the fire out. How do you find those people? What are you looking for?
Well, it's interesting. I think Australians are pretty good at realising that when you leave our shores, not everybody's an Australian. No disrespect to other nationalities around the world, but nationalities with larger populations, Americans and Brits, might arrive and try to institute a bit of personal culture, local culture, rather than most Australians realise when they leave Australia, no one else is going to cash Australian money. You know what I mean? They've got to be in their culture. So we're pretty good at understanding that. The other thing is, because we have an international pool, 25 nationalities, we never overwhelm with one culture. So in Iraq, the majority of our staff were Iraqi. So subsequently, we were utilising an Iraqi model, but with the best that we were bringing from Australia and the US and Eastern Europe and the UK and everywhere else in those teams. So we run a database, a credential database of over 2,000 staff that we have ready to go. And then we have a broader database of about another 8,000 who we can call on. So, if we're looking at a disaster saying, well, we need a strong orthopaedic focus here, or we need a strong trauma response, or we need a strong infection control response, we'll go to tap those. So, for example, we got a request out of DFID to go into the Democratic Republic of Congo, and we went, fantastic, it's Ebola, we've got lots of people. Oh, by the way, they need to be French speaking. So, putting together a Francophone watch team to go in there, which we did, was really challenging, but out of the database, which is big enough, we could draw on that staff.
Which sort of wades into the spaces that you were exploring, Berna, in relation to this issue of cultural context, which is sort of an extension of this challenge of the universality of human rights, the principle that all lives are individually valuable, equally individually valuable, and that extends into the space of medical ethics you referred to, which is the fourth principle in medical ethics, which is the justice principle, that we need to look at how do we provide equitable access to our available resources. So in this sort of ethical space, which I said seems to be sort of an undercurrent in this disaster preparedness conversation, how are you proposing that you potentially could advise others to navigate some of that tension about universality and cultural relativism in terms of the delivery of services in the disaster context?
well, within our context, it was actually already quite difficult to come up with our priorities, right? And rightfully so, it should be difficult because when you're trying to align, get consensus on your priorities, each individual person who's providing their input are also reflecting on what's important to them. So when we went through our journey, we experienced a lot of difficulties, a lot of really lively discussions, a lot of difficult discussions, challenging discussions to get to the point where we got. In terms of universality, I think you should be able to possibly get to some very high-level consensus on what's important in medical ethics in times of disaster. But each, I think, culture will need to go and take that and understand what it really means for them.
Because it is an interesting challenge inside the health space. I know as an emergency physician that the way I'm trained, and you alluded to this in your presentation, is about a loyalty to an individual patient. And you've alluded to this in your conversations about patient-centeredness, which came up as well. How do we, and I'll start with you, Berna, and we'll sort of work across the panel, how do you work with this tension again between the way we're trained, which is that patient needs everything I can give them, and then you've got a mass casualty context where it is not actually physically possible to be able to do that. Mm-hmm. How do you kind of enter that space?
You got to have the conversation really early on. You got to be able to tell people this is exactly what's going to happen. You'll experience lots of dilemma. Should we actually enter into this space? Should a disaster happen? They need to be they need to know that it's going to happen. That dilemma that they'll feel within, because it's exactly what happened when we were experiencing a shortage on IV. And we needed to go and change some practices. And infection control was just no, we're not changing practice. And then risk management is all, well, risk to individual patient possibly getting an infection versus risk to people not getting their treatment. So it was, like I said, very difficult conversation that needs to happen way in advance before they actually experience that for themselves. They needed to be quite aware of it.
Bronte, you're nodding. Yes,
I am. So one of two things. Firstly, Ban Ki-moon's statement about as local as possible, as international as necessary, really goes to that localization for that, primarily for the adaptation into context and understanding, because everybody's norms are different and the systems are different. There's core elements of health systems that are the same, but irrespective of the resources you have, but those adaptations are already known by the locals, so you should never work in isolation of that. But for example, the minimum standards in the Blue Book for emergency medical teams very clearly talks about the training requirements for teams. And that is not just being a specialist in your own craft, but that's also having a good understanding of what the response sector and those global macro themes are, but also that you are working in accordance with the world ethics, on medical ethics, but you all provide specific training for your cohort to adapt their clinical practice into context. And so that's specifically giving them skill sets which they may not necessarily have, and having those conversations early and putting clinical scenarios and environment, really giving them a palpable feel of what that environment is going to be like. So the first time they encounter that physically, they've already conceptually thought about what it means to have more patients than beds, not 5 different formulary versions of how you would choose to treat something, not large amounts of technology. All of those things that we take for granted in our own home healthcare systems won't be in existence necessarily in the kind of context we're talking about, and they certainly won't be freely available. So you need to have had forward thought process around that. So that's a real deliberate focus about ensuring that quality care is provided. That doesn't mean no care. It might mean limitation of care, but it doesn't mean no care, and it means care that's as appropriate to the context and the environment.
And that's something, Glenn, I'd like to explore with you. You're ex-military man, and this notion of military triage, which is something that we refer to, and it's language which is changing now, but the principle that you can't provide care to all, but you try. How do you ensure that you try within the context of this dilemma between individual patient right, equal right, however, you're in a situation where you do not have the capacity to respond equally to everybody who might need you to?
Well, I think both points were very, very relevant around you have to have had this discussion first. So all of our policies, procedures, all of our guidelines, which, you know, as you said, we just had the joy of being audited by the WHO over the last 9 months, go to all of that. But the other bit that's critical is around resource levelling as well. You're not sitting there as an island. Whether we worked in Africa or, you know, you were referring to Haiti, while everybody was focused on Haiti, we were doing 2 cholera response outbreaks in PNG that got no international news and no attention. You know, Angelina Jolie was in Haiti. Nobody was worried about PNG's cholera outbreaks. So the resource levelling is what you've got to do to work amongst everybody else. That coordination was critical on the ground in Africa, both in Sierra Leone and Liberia and in Iraq. We were running the only ICU unit and the only neonate unit and the only chemical weapons treatment unit in northern Iraq. And so subsequently, at times when we could have dealt with surgery, we would refer off to the MSF or Save the Children or Partners in Health Hospital so that we had capacity for the incoming chemical treatments we knew were arriving. Now, the delay of care to those people was something that was challenging. But we knew what we had to do to be able to treat the largest group of people in the best possible way rather than only looking at a particular case. Having had that discussion and training everybody in that in advance is really, really critical. But the other thing is that you have ongoing training. And so we were training all the time while we were in country on all of those projects because, you know, we all fall back to habits. And you've spent a lifetime in clinical care developing habits around patient-centred, best possible care, and so you have to reaffirm those things on a pretty regular basis during a deployment.
I saw that in your list actually in relation to your Mosul example where you had your deploy management and trainers, and it was very early really in the piece, which is this issue about how do we ensure not just the scenario, the drilling that we all know in clinical care, that we're drilled again and again so that it becomes second nature. Of course, the problem with disasters is that there's nothing second nature about it's total adaptive in the moment. And that goes to a point that you raised, Berna, about moral distress, which is an extension of this. We've got the policy, we've got the principles, we've got the training, and then we have the humans providing the care. And as a health practitioner, anybody in the health practitioner space, I'm sure that those of you in the audience who are actually practitioners in this space know the challenge for yourself of being the human working with humans in distress. And this is mass distress. So we're talking about how do you deal with that and avoid that challenge of the vicarious trauma that comes. So just, Berna, just to your point about, you mentioned your own experience about that moral distress. Can you sort of explore that a little bit for us more about how do you kind of propose or some suggestions about how to actually open that box in a constructive way?
I think, again, awareness. Awareness is key. So when I became aware of what I was feeling, realizing that I actually was having moral distress because of the decisions I was having to make that I wasn't really quite prepared for. Being open to admitting that, open to letting the organization know that something's needed there. There's a missing something, a gap that we need to fill so that our people don't feel the same. And I think it's that willingness to go and recognize it and put it on the table and for everybody to come together to figure it out.
It's an interesting challenge because I know statistically they say about 10% of people who experience a one-off trauma, this is the recipient of the trauma, will actually probably, for want of a better term, get over it. They'll actually find a way to move on with their life. But anybody who's exposed to repeated trauma, which would be argued to be health professionals and others working in these complex spaces, that becomes a greater challenge in terms of how we navigate that. And I know that in the health system more broadly, we're seeking to try and work out how to do that. And that's the health system more broadly question I want to now explore is that hospitals, as entities, bricks and mortar, fixed, generally speaking, don't occupy these more, for want of a better term, exotic locations that these disaster events occur in. What do you think are the ways, from your experience, either current or proposed, to start with you, Bronte, about how hospitals can engage most constructively or be engaged most constructively in this space?
in terms of, well, you're the workforce. It's the first part. You have the clinicians and the logisticians and the staff, and so I guess that preparedness for response goes at multiple layers. And let me give you the Australian example. So AUSMAT is the Australian Medical Assistance Team. It's the Australian Government deployable healthcare team. But the workforce comes from each jurisdiction in Australia, from the health services that are working on a daily basis. And they use that training, common training that we give them to be their domestic response, right at a hospital health service level, up to a state or a jurisdiction-based level, and then that feeds into the national team. So there are elements of relevance that go to each of that. There is a lot of awareness training that goes on. There are a lot of international agencies and organisations like Glenn's that you can, if people are interested, they can join and express an interest, but still go through those same minimum standards of preparedness and training. The Red Cross, Red Crescent Society does remarkable work in this space all around the world, and there are lots of different ways that you can choose to get engaged and support the cause, I guess, if you like. But for me, it's equally recognising and allowing there's a need. But if you're a director of nursing and a nurse in your workforce comes to you and says, I want to go and work in Sierra Leone, or I want to go and do some work with MSF, or I'd like to take some leave to go and do this, there's value in that. They bring that back. That skill set and experience they get when they go away, they bring back to you and your organisation. That flexibility, the adaptability, the cross-cultural context, all of those things, the remarkable experience they get, they bring back to your organisation, and there's value in letting them go to do that, to bring that back and share and grow that amongst your workforce.
So that's very much a pitch to try and encourage the releasing of staff in a system that is struggling with its own staffing challenges. Yep. And that goes to your point, Glenn, about finding the people, which we had before, in terms of your relationship as an organisation formally outside the hospital system. How do you go about liaising with the more traditional hospital-type health provision structures in relation to the work that you do?
Yeah, I might. I think there's two things to understand here. One is, it's very interesting from Berna's point of view, that's a disaster response within our own context, so within our own jurisdiction, as opposed to what we're typically talking about is a disaster response in someone else's context, someone else's scenario. And I think they're two different things that need to be looked at. We ran a department in a hospital here in Queensland a few years ago, and part of its emergency response was if there was an accident at the airport. And that would have been, if you could have imagined, you know, several hundred people, everything from Cat 1s to 5s, the whole 9 yards, overwhelming. That sort of disastrous scenario planning and development, I don't think we do quite enough of that. I think we need to do more of that. That's why people became health professionals, to be able to deliver that sort of care. So I think we need more of that. The secondment piece is really critical, and it is so patchy. So we don't just do the overseas deployments, we run Indigenous health projects. We've put over 5,500 health professionals into remote Indigenous projects across the Northern Territory. They have to come from metro areas because we don't want to be thieving them from one Indigenous health area to go to another. We're just moving deck chairs. So we want to prime the pump. And a lot of health professionals would love to do that work, but they go, well, hang on, which community would I go to? How would I get there? Will I have all the clinical skills? What if I don't feel safe? They get to about the third question, goes, it's just too hard. So we answer all of those. When they go home, even though they've been in a disaster zone, being in such a different environment in a remote Indigenous community, they come back with a much clearer understanding of managing use of medications, understanding treatment of patients, chronic conditions, adaptability, agileness, all sorts of things. They're critical. When we did the Ebola work, we initially won the contract for the US government, and the US government didn't want us to publicise it because, to be honest, they were a bit embarrassed that no American company could do what we were doing. But the trouble was the Australian government at that time put a lockdown and said any health professional who goes won't be allowed back into country. And we said, we've got 200 health professionals who want to go. The skills they will bring back to give our hospitals an understanding of pandemic treatment will be critical, because we will get one somewhere at some stage. So I actually think not only does it produce a real benefit, but I think we actually need a plan. I think we need a systemic, state-based plan that talks around secondments. not only will it grow our own internal capacity, but to be honest, it'll mean people will stay longer. Because rather than saying, well, I'm a bit bored, so I'll have to resign and go to MSF or Aspen or somewhere else, they can go, well, I've gone and had 4 weeks, and that was great, but you know what? Puckapunyal is fantastic, and I love living here after all, or wherever they're from. And so I think we could do ourselves an enormous amount of strengthening with our hospital system and our own capability purely by managing a secondment system that would allow easy release and training.
And on that note, unfortunately, we actually are out of time. As you can see, this is a fascinating, complex, emerging space in the era of teams and international cooperation and an underlying ethical framework, and also looking inside our own practices, realising that the workforces are being drawn from the domestic spaces, and we need to have some bridging conversations and then some policies potentially to put in place to facilitate the release of those people, as well as the support for those people pre, during and post. Thank you so much for joining us for this morning session. Could you please thank our 3 speakers? First up, Berna, Glenn and Bronte.